Hello, everybody. Welcome and thank you for joining us here today. My name is Fabiana Bacchini. I'm the Executive Director of the Canadian Premature Babies Foundation. And since the beginning of the pandemic, we decided to host Facebook Lives, bringing experts from all over Canada and parents to talk about what is happening there in ICUs across the country, what parents are facing at home or in the ICU with their babies. So you can join us every Monday and Friday, 1 p.m. Eastern Time here on Facebook. And every Wednesday, Kate Robson, who is a psychotherapist and a mother of 2 premature babies, is hosting a real-time support group here also on Facebook. But to access that link, you have to join the Canadian Preemie Parent Network, which is our private parent group. And today it is International Kangaroo Care Awareness Day. It's a very important day for any parent around the world, but especially for parents who have babies in the NICU. And to talk about this subject, I have the best nurse in Canada. I can say that because I know her work. She's a champion for Kangaroo Care. Her name is Diane Schultz. She's a staff nurse at Boniface Hospital in Winnipeg. She's the co-chair of the FiCare committee and member of the National FiCare Steering Committee. She organizes the annual Kangaroothon through Sunnybrook Hospital and educates staff at all levels on the benefits of kangaroo care, including transfer techniques. Diane, welcome and thank you for joining us here today.
Hi, Fabiana. Thanks for inviting me.
Thank you. Diane, I will start by asking you where this practice is started.
So this practice for premature babies anyways kind of started in 1979 when Dr. Reyes and Martinez were in a small remote village in Colombia and witnessed a grandmother holding their grandchild in between her breasts. And they commented that it looked like a kangaroo holding its baby. And in their NICU in Bogota, they had a high infant mortality rate due to bed sharing, not proper cleaning techniques, and very few sterile techniques too. So they thought they could increase their infant mortality or improve it by trying kangaroo care in their NICU. They then presented it to the world in 1983 and presented that their infant mortality rate increased by 70% after a year of initiating kangaroo care. So, and the thought behind that is it provides warmth, thermoregulation, nutrition, and protection for the baby.
So if we simply explain what kangaroo care is to families who are just starting this journey or sometime, or perhaps mothers are still pregnant, how can we tell them what that is?
So kangaroo care specifically refers to premature babies, but kangaroo care, kangaroo mother care, or skin to skin all refer to the same thing, which is a diaper-clad infant held chest to chest, ventral surface to ventral surface with its mother, father, or caregiver.
It's such a wonderful practice. I actually had the chance to go to Bogota a few years ago, and I went to a public hospital in Bogota where they had those white plastic chairs in a level 2 NICU, and I saw these very young moms holding their babies at kangaroo care, and I was so impressed that I didn't know Head Start in Colombia, and to see the practice where it all started was amazing. But then tell us a little bit about the importance of kangaroo care for any baby.
So the importance of kangaroo care is important for all babies and all caregivers. For your term babies, it increases your rates of breastfeeding, improves your attachment and bonding with the parent and the caregiver, decreases the cortisol of the baby, so it actually improves the transition after birth. Thermoregulation is just an automatic with the mother and her breasts because her breasts automatically thermoregulate for the infant. It also improves sleep patterns for the term infant. Benefits for the mother are improved breast milk production and again, increased breastfeeding rates, a decrease in cortisol for her too, because birth is a very stressful event. It actually decreases the risks of postpartum and decreases her blood loss because kangaroo care increases your oxytocin, which increases your uterine contractions, which actually decreases the blood loss for the mother. It is very important for a father too, and they've done studies in third world countries where they've proven that if the father held skin to skin, he was less apt to leave the family. So in developing countries or developed countries, it's extremely important. If you were to look at the benefits for the premature baby, it's the same for all the ones that I've noted, but you also get improved brain maturation because that premature baby actually has improved REM sleep. We do a lot of negative touch in our NICUs, and we disturb those babies an awful lot, and they don't get the proper REM sleep, and that's when you actually mature your brain. So it also blunts the pain or the brain's response to pain. And again, we do a lot of negative touch, a lot of painful stimulations, heel pokes for blood work, IV starts. And if that baby is held skin to skin during that time, it actually blunts the pain response to the brain, which actually blocks that memory of pain. And there's a lot of research that talks about painful memories. Stabilization of vital signs for our premature babies always happens too. And the thermoregulation is just a given. If you do twins, each breast on the mother actually thermoregulates separately for each baby. So if you have a cool baby and a hot baby, each breast works independently to thermoregulate that baby. Again, improves breastfeeding rates for your premature babies. I've seen 24-week infants discharged home with exclusive breastfeeding. And I really feel it was due to the amount of skin to skin that mother and father did for that baby. So, and it's just as important for the fathers in our units too.
That is amazing. And it's something that, it doesn't require much because it doesn't require special equipment, it doesn't require a special chair, because what I saw obviously is not that comfortable for mom if the chair is not comfortable, but it shouldn't, it shouldn't be a barrier for not doing kangaroo care if you don't have a recliner or a fancy chair or anything like that, right?
Yeah. We do now have specific chairs that we use in our unit, but prior to getting them, our parents would hold for hours if they had the opportunity to hold their baby skin to skin. And I was in Bogota a couple of years ago too for the International Kangaroo Mother Care Conference, and we got to tour some of the NICUs and to watch them hold their baby skin to skin and then discharge their babies and stay skin to skin throughout once they've gone home. So it's extremely important.
So Diane, just going back a little bit on babies who are actually term in labor and delivery, is that a practice or recommendation right now for the baby being placed on mom right away?
Yes. So what we do at our hospital, we've adopted delayed cord clamping in the last few years. So that baby goes up onto mom's stomach for that first minute. And then after we've clamped the cord, that baby does not come off of mom unless we need to intervene. But generally that baby goes right up onto mom's bare chest and sits there for the first hour or until the first breastfeeding before anything else is done. And you can do assessments for that baby while they're on mom. In our hospital too, we also monitor babies that have mild respiratory distress after birth on their mothers. We place an oxygen saturation probe on their wrist and we monitor them that way. And we've had great success by doing that. Our old practice was to take the baby to our observation unit and monitor them. But if all you're doing is monitoring, then that baby should not be taken away from its mother. So we actually treat them the same way, but we stay there with the mother and monitor that. Also in our hospital, we now for almost 4.
Sorry, Diane, we lost you for a second. Can you repeat in your hospital?
In our hospital for cesarean sections, it's been protocol now for about 4 years that as long as mom and baby are well, that baby is placed skin to skin on mother in the section room as soon as possible. We do have to go transverse wise because of the sterile field, and I had never really understood or really witnessed the breast crawl before, but now that we put these babies skin to skin at a section, you actually witness the breast crawl. And we've had many infants latch and successfully breastfeed while they're closing mom up. And our obstetricians will tell you they don't have to look over the drape to know that mother is holding that baby skin to skin, because the uterus has gone like this. So again, it's decreased our blood loss at our cesarean sections too.
That is incredible.
Yeah.
Diane, but for the babies in the NICU, is there a time where babies should not be held because they are very sick or because they are intubated? Because I remember when Gabriel was on a ventilator, on the oscillator, the one that makes a lot of noise.
Yeah.
It was extremely hard to bring him up, and I wanted to talk about that later on the transfer. But I know it took so many people to have a safe transfer for me to hold Gabriel on ventilator. Is this something that we know it's good for the baby, even on ventilator, or if they are sick, to be on that position with the parent?
Yes, we do know that it is very important for that baby. In our unit, we follow the EPIC guidelines where the first 72 hours, babies born less than 27 weeks stay midline. So generally for those babies, they don't come out for skin to skin in the first 72 hours. After that, it's a case-by-case assessment, and it should always be an individual assessment for each baby anyways. But we do take a lot of our staff, and we've trained our staff. Our respiratory therapists are involved with every baby that's intubated. And we do take out babies that are on the oscillator or the jet like Gabriel was. And it's actually regular practice in our unit.
Wonderful. So for the parents, you can always ask their medical team if it's appropriate that if baby is stable enough to come out, right? It's a conversation that we can have with the medical team to analyze the case by case.
Yeah, we did encourage our staff to discuss it in rounds each day and or have our parents ask. But in our unit, like the staff I work with are incredible and amazing. And we generally don't even discuss it. It's just, okay, let's hold your baby. And we bring them out. So, and tiny, tiny, tiny ones too.
Wow, that is so wonderful. But Diane, I want to talk about you, because when I met you, I knew that you were so passionate about kangaroo care. How did that start? How did you become so passionate about this practice?
Well, I met Susie Ludington just over 10 years ago at a conference where she was presenting the benefits of skin to skin and kangaroo care. And it really kind of blew my mind. And we were doing it to some extent, but it wasn't a common practice. So it just made me feel that this was something that really needed to happen. And we brought it back after the conference. And again, because of the incredible staff I work with, it took us a while to adapt it and fully figure it out. And how can we make this work? And how can we make this work safely? But kangaroo care and skin to skin will actually provide its own evidence for you too. So you can watch that parent fall in love with their baby while they're holding them. And our parents really have very little control at the bedside. So this gives them a lot. And it shows that they are the most important caregiver at the bedside. We are an important part of the team, but the healthcare workers are there for the short term, where the parents are there for the long term. And those parents need to have that relationship with their baby. So yeah, no, we've really worked hard in our unit to make this a common practice.
But Diane, you also created videos teaching the nurses and your team on transfer. And we have the video available on our website, thecanadianpreemies.org, in the blog that you wrote about you this week. And we're going to put the link here on our feed. This is an incredible video teaching the staff how to transfer, but also showing parents transferring the baby themselves. Talk a little bit how did you come up with the idea of the video? Because it's a step by step how to do that, even with babies on ventilators.
Yeah. We started creating a poster that we did take to a few conferences to present our transfer technique. We went through the evidence and couldn't find too much about it. And our sick intubated babies, our fragile intubated babies, we used to transfer having the parent pick the baby up. And we just found it wasn't a stable transfer. And if the transfer didn't go well, it actually made the parents feel really bad about the experience. Whereas the nurses, from the very beginning of the infant's life, we're more comfortable in touching and holding and moving those babies. So all our intubated babies get transferred by the sandwich or nurse technique, where we sandwich the baby between our hands. and you're only responsible for holding that baby. The respiratory therapist maintains the breathing tube, somebody else is maintaining your IVs, and it's a very slow, controlled transfer. So, and then by the time the baby's extubated, then we start educating the parent on picking that baby up by themselves, not by themselves, but with our help. And that's called the parent transfer. So we use both transfer techniques in our unit for 2 different instances. But anytime we have a parent that is uncomfortable picking that baby up, or is a fresh section, is in a lot of pain, or the baby is just a little more fragile, even if it isn't intubated, we still revert back to that nurse transfer just to make it a more calming experience for the baby and the parents. So we have presented that video worldwide. And yeah, it goes over really well. We also created a standard work for our hospital for all intubated babies. So the intubated babies get transferred out for skin to skin the same way every time. So it's a real team effort. We try and have a briefing beforehand, and then we try and have a debriefing afterwards as to what went well, what could we improve on. And we encourage the parent to really pay attention to the transfer technique, because they are the expert at the bedside. I can come on and not have a baby, but that mother or that father is at the bedside for hours. So you really have to respect the fact that the parent is the expert and knows their baby in and out, and what goes well, what they like, what they don't like. So.
And that is so important, because I remember when I used to hold Gabriel in the NICU, the nurse always said, do not look at the monitor. She actually made me sit behind, in front of the monitor. So the monitor was behind me, so I wouldn't look at the numbers, but really understand my baby's cues, how he was doing, to really know him, right? Yeah. So because the monitors are not going home.
Yeah.
Eventually we did bring the monitor home because he came home on oxygen, but we didn't know then that was going to be the case. But it was so important, reassuring to me that I holding him, I could see the color of his lips and his face well.
Yeah. So, and then if they do have an event for that parent to look at that baby and recognize the color and the change in color and what they can do, because if it's a brady or a desaturation, they can always rub the back of their baby too. So, and we really encourage our parents to be there from the very beginning, regardless of how fragile their baby is, because they need to be there, and that baby needs them to be there.
Diane, but when parents we cannot bring the baby out. There's other ways that parents can still touch the baby. There's different kinds of holding or touching the baby. Talk a little bit about that.
Yeah. So that's called hand hugging. And again, with our babies born less than 27 weeks, for that first 72 hours when they can't come out, or if a baby is very, very fragile, we generally in our unit have not brought out a baby for skin to skin with a chest tube. So certain things like that parent should still definitely have their hands in the isolette or on the open bed on their baby, touching and talking to them at all times.
That's wonderful. So I'm going to switch gears a little bit, because there is something that you're also very passionate about, which is integrating families in the care of their babies, every aspect of that integration. That's why you're sitting on this Family Integrated Care Committee. How did that become a practice for you? Because I know you've been nursing for 30 years, and I believe at the beginning, it wasn't common to have parents engaged, but now we have this movement, this model of care. The parents are welcome to take care of their babies in the unit.
Yeah. We try not to think of our parents as visitors in our unit, because they really aren't. They're the ultimate caregiver for that baby. So FiCare, Family Integrated Care, just was a natural progression. I knew Marianne Bracht through research, and she always talked about her parent groups. So we kind of started having parent groups before we actually heard about the full study of FiCare. And then when it was presented to us, it just seemed like a no-brainer, because Kangaroo Care is such a large part of FiCare that it seemed we were doing so much of it already, that let's bring it further and enable those parents to be parents at the bedside at all times. Right now, because of COVID, of course, we don't have rounds at our bedside, but we regularly have parents introduce their baby and or present in rounds in our unit. And also, too, they are then able to recognize themselves as an integral part of their infant's care. and that they are actually part of the team. And then anybody in rounds, they're not afraid to ask questions of either. So it just kind of goes hand in hand, Kangaroo Care and FiCare. Right now, it's a little more difficult, but we still highly encourage parents from the very beginning of their birth to celebrate the birth of their baby. They're touching and holding their baby, talking to their baby. We're really encouraging reading to our babies now. We also are putting a protocol in place for end-of-life care and or resuscitations and parents being present at the bedside. So you really want them to make that choice. If they want to be there for those situations, then they really should be there.
Absolutely. But let's talk about the pandemic now, because you mentioned that things have changed, and we obviously know things have changed all over the world in the NICUs. And every Friday, I have a call with parent organizations from all over the world where in many hospitals in Europe and Africa, the families are not even coming to the hospital because they don't have enough PPE, they can't test the parents. And it is being a real struggle for families all over the world. And in Canada, hospitals have different policies. Yeah. And as far as we know, most of the hospitals are having one parent at a time by the bedside. So how does have changed in your hospital, and how are you still engaging parents in the care of their baby at this time? Because we don't know how long that's going to last.
Mm-hmm. I have a feeling it might last for a while. So in our unit, we are only allowed one parent at the bedside at any time. We have no time limit to when you're there or at time of the day. Like, we regularly have some parents that show up during the night or late. We don't limit that at all. So we've had both parents come to the hospital. They just take turns in and out of the unit. We still, like I said, we don't do rounds at the bedside now. Rounds are done off-site. So we have discussions ahead of time about questions or concerns. And then generally somebody will come to the bedside, and if the parents are there, then have a conversation with them and update them on the plan of care. Again, our doctors are available for our parents to discuss and talk to. We still have social work and spiritual care as support for our parents. It's just a little different than it had been. So we do have to practice social distancing. Mm-hmm. I believe there is some support otherwise, like for risks of postpartum depression, things like that. I think we can get quicker access to that if we think it's needed. We at the bedside have to mask and wear a shield and or a visor at the bedside at all times, and then we gown and glove every time we touch a baby. I find personally that that's created a barrier between myself and the family. And you don't notice it, but I had to change my mask one day inside the pod, and I had had this baby for a week. And this mother's like, "Oh, that's what you look like." So it's very different, because if all you see is somebody's eyes, you miss a lot of the facial expressions, and it looks quite flat. So a couple of evenings, we've gone and drawn lips on our masks, different things. So you try your best, but our parents are still involved at the bedside as much as they were. It's just unfortunately that we can only have one parent at a time. If that baby is critically ill, we have allowed both parents at the bedside. So, and in our province, we're quite lucky because our numbers have been very, very low. So, but just the PPE that you have to wear does create quite a barrier.
Absolutely. And I really appreciate all the efforts that your hospital is doing to keep parents together, because it is challenging times. Absolutely. Yeah. And we don't know how long this is going to be. But the fact that the parents are still welcome in the unit to stay with their baby is so amazing to hear from your hospital and many other hospitals across this country. So we should be very proud of ourselves as Canadians to still allow that, because it's not in every area of the hospital. This is an NICU practice and some in the pediatric hospitals, because we know what's happening in the adult population. Yeah. So I think everybody's trying their best, and yes, and I cannot even imagine how hard it is to work with the PPE. And I've seen, I share with you,
especially when you have hot flashes.
And I share with you what some hospitals are doing. I think I sent a picture of sick kids that has a picture of the nurse and the doctor, like the real face is smiling, so the kids are not afraid of the mask and the visor, right? So it's not that there's a person behind all of this.
Yeah, we are going to talk about that next week and see if we can create something.
Oh, that would be lovely. Share with us if you do.
Yeah.
So Diane, I have one last question to you, because today would be the very last day of the Kangarooathon in Canada, that every year for 6-7 years we look forward to it, to see hospitals competing among themselves who's going to have more kangaroo time with parents. And this year, unfortunately, it didn't happen.
Yeah.
So tell us a little bit about how did this Kangarooathon started, how was the evolution of that, and what is happening now?
So the Kangaroothon started with Sunnybrook. I think it was about 7 years ago, and it actually became an international competition because there was so many hospitals outside of Canada that competed. So unfortunately, it didn't happen this year, but we really feel in our unit that it is so important to do anyways. So this year we did have our own Kangaroothon that started on May the 1st, and today will be the last day. Our unit, we keep track of our hours. Right now, I think we were sitting at 400 hours over the 2 weeks. It's very hard to calculate it because we also keep track of our skin to skin at our sections for our tally rates. And you have some babies that stay in for an hour, like a few hours or a day, and then are gone, but they end up adding to your numbers of patients. So, but we regularly have parents that will hold their babies for hours in our unit, regardless of how fragile they are. Our entire maternal child department has competed before with us. Like, they participate at the same time at a different level. And this year, our labor and delivery, their challenge was to increase their time transferring skin to skin from labor and delivery to the postpartum unit. So they were working hard on that. And then our postpartum unit was working hard at making sure that those babies were skin to skin during heel pokes or painful procedures. So that was their challenge this year. Mm-hmm. So, and today we do have kangaroo cookies that are being dispersed throughout the 3rd floor. We have prizes for our parents and prizes for our staff too. So
this is wonderful, Diane. Congratulations on keeping this going. It's so very important. And I'm looking forward to seeing the pictures of the cookies. And I do hope that next year we can resume the Kangarooathon across Canada. I know Australia is also involved. Yeah. They also canceled this year because of the COVID. But it's so great to see you, to hear from you. Always a pleasure. I always learn so much from you, and the way you share your passion to support families is always so very inspiring to me. So thank you so much.
Yes, thank you for having me. It was fun.
Thank you. And for all of you at home, thank you so much for watching us. I will be back on Monday. I'll be interviewing Mary Lee Brockway. She's a nurse from Calgary. We're going to be talking about breastfeeding during the pandemic and all the amazing research she's been doing on breast milk. And next Wednesday, again, Kate Robson hosts her real-time peer support group here on Facebook, 1 p.m. Eastern Time. And to access that link, you can join the Canadian Preemie Parent Network, which is our Facebook group. Thank you so much, everyone. Have a lovely long weekend across Canada. Thank you.
Thank you.